Klaus, you want to already share your presentation? We have the first slide.
Okay, good.
Yes, very good. Thank you.
Okay,
Okay, let's wait another half a minute before we start. Okay, number of participants is stagnating. I think we can start with this webinar now. So first of all, from my side and on behalf of my co-moderators, Eyab Shiban and Enrico Tessitori, welcome to this ENS webinar of the spine section, which we have tonight in our sequence of webinars. As always, we have one speaker. We'll have a discussion afterwards. For the discussion, as always, please use the Q&A box or the chat box, and we will read out the question for our presenter. Tonight, we're going to talk about one very common problem of the spine, but it's still a problem where clear treatment for several cases always is a bit unsure, and always asking what the right way is to treat those diseases. The topic tonight is fragility and fractures of the spine, current treatment concepts. And we have an important speaker on this topic. We have Klaus Schnake. He is the chairman of the spine section or the spinal department of the Waldkrankenhaus St. Marien in Erlangen in Germany. He's the chairman of the AO Spine Knowledge Forum Trauma and the chair of the spine section of the German Society of Orthopedics and Trauma, where he's very active and was co-inventor of a classification of those fragility fractures and a scoring of those fragility fractures. So he's a real specialist in the treatment and in planning and treatment of fragility fractures. And Klaus, we're looking forward to your presentation tonight to show us what the right way is to handle those osteoporotic or fragility fractures of the spine. Klaus, welcome, and we're looking forward to your presentation.
thanks, Florian. Thanks a lot for the kind invitation. Thanks to ENS for having me tonight. It's a pleasure to spend some time with you, together with you, and share some of our ideas and concepts we have developed over the past, I would say, 10 years with regard to osteoporotic fractures, whether they are fragility fractures or trauma. So I would like to share my ideas. These are my disclosures, and they're not really related to this talk. Just to give you a short introduction, because not all of you are aware where Erlangen is. Erlangen is a city, a university city close to Nuremberg in Bavaria. And this is where my spine center is located. And we are not only dealing with fractures, but mostly with degeneration. And we have a special aspect on deformity surgeries. So this is where we work. And now I would like to focus on the topic osteoporosis and fragility fractures. So the number and percentage of the global population over the age of 65 is steadily increasing. And by 2050, we will have worldwide around 17% which are older than 65. In Europe, as well as in some Asian countries, it's already like this. So we are focusing a situation where people get older and older. And with this, the number of osteoporotic fractures is steadily increasing too. When we see here the data 1990 to 2050, we see that for Europe, for instance, will almost double the numbers of osteoporotic fractures. So this a real problem we have to deal with. We have to be aware that these fractures are currently already, but will be the most common things we have to deal with in spinal trauma. In Germany, the incidence of fractures at all was 112 to 100,000 in 2019, but 2/3 already were over 70 years old. So the majority are older. And there was an increase over 10 years in almost in 20% in the lumbar spine and more than 30% in the thoracic spine. And mostly because of the elderly patients, mostly, of course, these osteoporotic fractures. And what is important to know is that the risk of a consecutive fracture within 1 year after the first fracture is about 20%. And if the patients have more than one fracture, this risk increases to 24% and gets even higher. So it's fractures of the spine are a real problem, osteoporotic fractures, because while in comparison to hip maybe or to the ankle or wrist, where you have only two, you have 12 vertebral thoracic vertebral bodies, you have 5 lumbar bodies, and you have the sacrum. So there are a lot of things which can fracture. And not because of this only, but because of it's an ongoing disease, the mortality after osteoporotic fracture is higher than in all the other fracture forms. So in comparison to hip, shoulder, forearm, you'll see that in spine, the mortality is steadily increasing. It's always higher than in the others. So it is a life-threatening disease, so we have to treat it, and not only surgically, of course, but with medication as well. I will come to this a little bit later. So we need to know a little bit about osteoporotic fragility fractures. And the most common facts are that they are mostly compressive or compression fractures. So they are either A1 or A3 according to AO Spine, but the AO Spine classification was not really made for these fractures. I'll come back to this later. Higher degree of instabilities in terms of B and C types injuries are rather uncommon. They account for only 2% of all the fractures. And neurological deficits are rare too, mostly radiculopathies, but very rare, compressives, or any kind of incomplete or complete spinal cord injuries. It's really rare. Progressive kyphosis, on the other hand, is quite common, especially if the T-score is very low. So the lower the T-score, the higher the risk of having an ongoing kyphosing. And there are different morphologies and natural courses in comparison to healthy bone fractures, so it's a different entity. And by just looking at the X-rays or the CT scan, you cannot distinguish whether the patient with osteoporosis had a trauma or just a fragility fracture. They look quite similar, and therefore we have created a classification which covers both. The only difference is that a patient with a trauma has typically a high degree of fracture, while fragility fractures mostly start with rather compressions and rather minor injuries. So in a combined effort of the German Society for Orthopedics and Trauma, as well as the AO, we have developed a classification which is called OF for osteoporotic fracture classification. It's relatively easy to remind. There's only 5 subtypes. I will just show you in a second how it looks like. It starts from a simple bony edema and ends with a severe deformity, and it reflects a typical osteoporotic fractures morphologies, and it's based on CT scan, MRI, and X-rays. So that's what it looks like. We have published this already in 2018 internationally, and it has become a kind of standard, at least in the German-speaking countries, and we have evaluated it already within the AO Spine internationally, and it is a reliable classification which can be used. And it starts with a simple bony edema, that's the OF1. Mostly you see this accidentally when you make an MRI, you're looking for another fracture, and by accident you see that there's another body is shining. Then the OF2 is a deformation of one end plate without or with only minor posterior wall involvement. Then you have a deformation of one end plate with a distinct posterior wall involvement. That's the OF3. That's something which we would say, well, it looks like an incomplete burst type injury. Then we have the group of OF4, which are deformations of both end plates with or without posterior wall involvement. So either complete burst type injuries, fishbone, or pincer type injuries. And then finally, the rather rare OF5, which are injuries with either anterior but mostly posterior tension band failure. So OF1 and OF5 are rare. They account for only 5%. The others are OF2, OF3, OF4. And the most typical one we have to treat surgically are the OF4 and OF5. Well, how can we treat them? There are different options, of course: conservative with or without orthosis, just the augmentation with kyphoplasty or vertebroplasty, or short stabilization plus minus an augmentation, or any kind of long stabilization, or even anterior posterior. And I will focus a little bit on this and tell you what can be done. So the typical therapy in these patients is a conservative therapy. However, conservative not always works, and round about 1/3 of the patients fail after conservative treatment, especially if they are old, frail, if they have a low T-score, less than -3, and if they have several radiological parameters like burst type injuries, like an initial quick height loss, like intravertebral clefts, when the fracture is located at the thoracolumbar junction, when they already have a decompensated sagittal balance or they develop it due to the fracture, and like in these illustrations here, if there are specific MRI fracture types where the anterior wall of the vertebral body is somehow affected and broken. So these are risk factors we know which can lead to a failure of the conservative treatment. And here's a case example of a patient, 79 years old. The pain started 5 weeks ago after just a rotation, so it's a fragility fracture. Now the patient came along while had pain while standing, sitting, and walking, showed a fracture of L3 as well as L4, had some typical comorbidities. And then we performed an MRI. We saw that there's a fresh fracture at L4 with a spinal canal stenosis, and the T-score was rather low with -2.9, so a risk factor for ongoing sintering and a risk factor for failure of conservative treatment. Then a CT scan shows that there's a mix, which is quite typical of old and fresh. So some parts at the L4 rather looks a little bit like older, but this can happen really even after a couple of weeks or several months, that the fracture is still active, but it's like it's an ongoing fracture. It's not really healed. It's not really totally sclerotic, so it's still there's instability. And the L3 fracture was relatively new. It was not even there on the MRI we performed a week before. So we have 2 fractures here. The L3 we would schedule or classify as OF2 because there's one end plate deformation and a minor posterior wall involvement, not a severe one. And the L4 is an OF4. That means both end plates are affected here together with the posterior wall. So we have OF2, excuse me, and OF4. And here, when the patient has still pain, suffers from kind of claudication, in that case, we stabilized this patient percutaneously, extended the stabilization to L3, and we augmented the screws, and we performed a minimal invasive, so micro decompression at the level of L3-4 where the stenosis was. Another example of a failed conservative treatment here, 86-year-old woman. She had a couple of comorbidities, which is common in this age. She was, on the other hand, she was not that frail. The frailty index was only 2, so I will tell you a little bit about the frailty index in a second. And she had a fall 3 months ago. Now, with increasing pain, VAS was already 8. She could not walk freely. She could not really stand upright. She needed the help, and she had no neurological deficit. And that's where the images when she came, we were able to hold her up a little bit and make an X-ray, and you see that's marked kyphosis here at this level. And in the MRI, you can see that there's a vertebral cleft and that there's elongated PLC. So the proximal ligaments are elongated, and therefore we would classify this as an OF5. And you see that the adjacent vertebral body is already affected. Typically, when this works over a couple of months, so that there's a force which is then acting or affecting the next vertebral bodies. Yes, canal stenosis, elongated PLC, as I said, and the local kyphosis was 50 degrees. So these are the APs, and here, of course, then there are different options, and we think that this could be a case for either a long stabilization. We performed a hypobocleon to see whether she opens up or not, but she didn't that much, to be honest, so that was relatively stiff. And therefore, we decided here to correct her in a very short but effective way with an anterior-posterior correction. First, we start with a percutaneous stabilization with PMMA augmentation of the screws and decompressed at T12, and followed by a thoracoscopic-assisted mini-thoracotomy, a corpectomy, and a vertebral body replacement. And this is how it looks like postoperatively. A lot of cement, a lot of metal, you would say, but it's quite effective, a relatively strong construct. And this is already a follow-up of 12 months. And even the sagittal parameters were not that bad. SVAF plus 8 centimeters is not perfect, but for an 86-year-old lady, it's acceptable. PILL mismatch was only 9 degrees, and local kyphosis was reduced to 16 degrees. And this lasted at least for 1 year, so that's the follow-up we have in this very old lady. So the decision when to operate depends on clinical as well as radiological parameters. Surgery is typically indicated when the pain is above 5 on VAS, when the patient is immobile or doesn't get really back to the normal mobilization. When you have a low T-score, which is a risk score, as a risk factor, what I told you. Of course, when there are neurological deficits, and if you see an ongoing sintering or kyphosing. Conservative treatment is most typically possible in a mobile patient with moderate pain, and if a patient is really frail or has a lot of comorbidities. In order to put this together a little bit and make it more practicable in our daily work, we created, so we as the German Orthopedic and Trauma Society, as well the AOSPA Knowledge from Trauma, we created a score. And this score, the OF score for osteoporotic fractures, combines all this and gives a help in daily clinical practice to judge whether a patient probably needs surgery or not. So it includes the parameter morphology according to the OF score, the severity of osteoporosis. You can either use a T-score if available or the QTCT. The Hounsfield units are below 90. If there's a deformity progression, if you see the patient at different time points, what is the pain under adequate analgesia? Is it still above 5 or not? What are the neurological symptoms? Do they have one? Yes or no? Is the patient mobile under adequate analgesia? And what about the health status? Here we account for the ASA status as well for the modified 5-item Fragility index. This is a very easy to index to assess. It only has arterial hypertension, coronary heart disease. It has the COPD, so chronic obstructive pulmonary disease, or pneumonia recently, and has diabetes, as well as it considers the situation in terms of nursing, yes or no, so how dependent the patient is. It's relatively easy to assess, so easy for surgeons. It's made for surgeons, I would say. And if this modified frailty index is above 2, the risk of any complications when you operate the patient is increasing dramatically, so significantly, and whether the patient has anticoagulation. So all of this gets into account. Like this point, even if you don't have information with regard to deformity progression or the severity of osteoporosis maybe, or you don't know all the health status, you can still use this score because it even works if you have only morphology, pain, neurological symptoms, as well as the mobilization. So even with this, you can use the score. And the score idea was to say, okay, if there are more than 6 points, we would recommend surgery. If there are less than 6 points, we would recommend conservative treatment. So to give you an example how this works, one example here, it's a fracture of T12. It's with an incomplete burst type injury. So one end plate is affected with a distinct posterior wall involvement. So it's an OF3. Pain was relatively high, 7, and the patient was bedridden due to the pain. And here, when we use the score, we see that there are 6 points for the morphology, 1 point for the bone mineral density, another point for the pain, another point because the patient is not mobile, and the overall health status was okay, but despite an active anticoagulation, and here the results would be 8 points. However, we typically treat all patients for a couple of days until a week conservatively to see whether they get better or not, and the score can be taken every day. After 1 week, we took the score again. Nothing really changed except that the anticoagulation was gone. So again, 9 points surgical therapy. In that case, we performed a short percutaneous stabilization with PMMA augmentation of the screws and the kyphoplasty of the affected vertebral T12. And this is already a 6 months post-op image. So this score actually is a help in daily practice. It's not, you don't have to use it, but it helps. And in order to evaluate it, we performed a multi-center prospective study in Germany. We included 17 centers, 518 patients, 174 got conservative and 344 surgical treatment. And we saw when we evaluated that the surgical patients had more severe fractures, which is understandable. They had higher pain and lower mobility, so the OF score was higher. The overall complications were rather acceptable, I would say. In the conservative, they were, of course, relatively low, 3%. In the surgical group, we had 13% of complications, although the complications were mostly medical complications, rarely surgical. And all inpatients improved clinically, but significant better improvement we saw with regard to the mobility in the surgical group. So surgery typically leads to a quicker return to the mobility level patients had. So patients can typically walk out of the hospital. We have looked at our own data in my clinic. So we included 84 patients, 60 could be evaluated. The T-score, as you see, was really low, -4. Average age was 76. And out of these 60 patients, the half of them got kyphoplasty, the other posterior instrumentation, and the other 24% kyphoplasty. And of course, we had conservative patients as well. The majority of patients had OF4 type fracture. That's quite common that you see them coming to the hospitals because OF1, OF2, and many OF3 can be treated as in an outpatient setting. And if you look on the right side, you see the OF score points, and you see that the watershed of 6, where both surgical as well as conservative treatment are possible, is relatively low. Only 8% of the patients had an OF score for 6. So the others had either a clear indication for surgery or is clear indication for conservative treatment. And what we found is that the patient who were treated according to the score developed the minimal clinical important difference in the ODI as well as the VAS over time to the last follow-up, which was on average like 5.5 months post-treatment. So you can see here that patients got better in both groups, but they were quicker mobile in the group of the surgical patients. And what is very important is whether the patients get to the same mobility level like they had before the fracture. And here, the OF concordant therapy, so the therapy which followed the OF recommendation, whether surgical or not, led to quite good outcomes. And you can see here that the mobility compared before the fracture and the follow-up was more or less the same. So 95 or 97% of the patients got back to the same level of mobility like they had before the fracture. And I think that's quite important for these old patients, that they get back to the same mobility level. We have published this in all these data in a recent special issue of the Global Spine Journal. There's this study here where we put all the data from the 518 patients and from the 17 centers. And in this work, we concluded that patients treated according to the score's recommendations showed favorable short-term clinical results. Short times means up to 6 months. But this is, I personally think, the most important time that the patients get back relatively quick out of the hospital, back to their normal daily activity level. We looked further for the OF4 patients. So we had 152 patients who had an OF4 fracture type. They received both non-operative as well as operative treatment. And here again, the OF score was a meaningful aid to decide whether these patients with this higher degree of fractures can be treated non-operatively or surgically. So again, the majority of patients who received surgery got this short fixator, this percutaneous fixation with PMMA augmentation. And finally, we checked the rather rare OF5 fractures. We had 19 in this group. They mostly received surgical stabilization. What we found here was that the clinical results were quite good, actually. However, we had a 45% postoperative complication rate. Again, mostly medical complications, and we had no death in this group. However, if you are rather aggressive in these elderly patients, you will inevitably see some complications. So to say, well, what kind of fractures, how can we treat them? The surgical options we have, I would just go through them. So we have the augmentations like kyphoplasty or vertebroplasty, which are suitable for OF1, 2, 3, and OF4 as well. Mostly we perform kyphoplasty. We rather use vertebroplasty, but this is whatever you like. However, kyphoplasty, as you know, has a lower cement leakage rate, and quite interesting, just a recent meta-analysis revealed that kyphoplasty especially reduced the risk of mortality by 18%. And in a subgroup analysis, there were already 71% reduction in the short-term follow-up. So kyphoplasty is an effective treatment, not only for pain, but it can obviously reduce mortality. Quite interesting, I think, and something maybe we can discuss later. So we have performed an own study, including 156 patients with 0.3, 2, 3, and 4 fractures, and they received kyphoplasty. And what we found, again, there's a significant reduction in pain, and that in the 0.3 and 0.4 type fractures, even the vertebral body height could be increased and the local kyphosis could be reduced. And therefore, we think that kyphoplasty is even possible in the subtypes of 0.4 fractures, but you should not use it when there's a marked posterior wall involvement or when there's a high degree of comminution, because then the cement cannot really work. Then the cement will probably leak out of the vertebral body. But otherwise, it's a very effective treatment. In all the others, short percutaneous hybrid constructs are meaningful. Is a meaningful option, especially if you have some like a local kyphosis, if you want to correct it. If you have a vertebral body which you cannot really augment, then these short hybrid constructs are really powerful. However, they are not really good or great data in terms of RCTs, or not so many prospective studies, but the studies we've seen, mostly retrospective, show that the complication rate is rather low, that the patient's outcome is typically quite good, and that there's relatively minor loss of reduction over time and not so many implant failures. So this works in many cases where kyphoplasty alone or vertebroplasty alone is not meaningful. The long open or percutaneous hybrid constructs are sometimes necessary for some subgroups of 0.5 and 0.4, or if you have like multiple fractures, then we typically today advise to cement the uppermost and lowermost screws, not all the screws like you can see here in these examples. So today we think that it's enough to cement the uppermost and lowermost screw pair, but not all the screws, in order to reduce cement leakage, which typically occurs if you cement screws. Anterior posterior constructs as well as osteotomies are sometimes necessary. We have already showed you an example, and therefore this is sometimes necessary in order to achieve good results, but today we can do this in a minimal invasive fashion. I would just give you an example here of an 81-year-old female. She had a severe osteoporosis, a fracture of T11 and T12 over 5. So the posterior elements were elongated and gone. She had an O score of 12 points, so it was a clear indication for surgery. You can see here that this is already a long situation which lasts for a couple of months. So the vertebral body is gone. You see this cleft, so it's open up. And if we go back and show you the standing image, you see the marked kyphosis, and in the supine position, you see how it opens up. So it's really unstable, and therefore here I think a long construct is necessary, as well as something to put in the front. And today we can do this in a minimal invasive way. We performed the percutaneous screws fixation from the back, and then with a mini thoracotomy, this is 6 centimeter incision, 2-level corpectomy and a cage. And these are already images 1.5 years after the surgery. That was the time we could follow her up. Today, I would say it would have been better probably to extend a little bit, maybe the fixation to the mid-thoracic spine. We stopped here at the level of, I think it's T9, and the patient developed an adjacent fracture, but was not in that pain, so we didn't have to revise her. So we had a follow-up of 1.5 years, and I think that's fine for this old lady. However, we have still some unsolved questions, like what about the length of the stabilization? You can see here examples where short examples as well as long examples where it failed, so sometimes whatever you do, it can fail. So these implant loosening and implant failure is a problem, is still a problem, and we do not have the ideal answers to solve it. So sometimes short stabilization works, sometimes not, and even sometimes long stabilization do not work. So that's difficult. And something we are focusing right now is what happens if you have a pre-existing clinical relevant degeneration. Like in that case here, you can see the patient had a fracture, and in the lower lumbar spine, some degenerative spondylolisthesis, plus old fractures, plus spinal stenosis. And this patient here was suffering from claudication before he got the fracture. So there was a question what to do. Should we address only the fracture? Should we do both? We decided to address both, but is this good? Is this meaningful? That's a thing we have to discuss. So another unsolved question. Just one slide regarding the pre and postoperative medical treatment. So I think it's crucial that all the patients receive not only vitamin D and somehow calcium, but specific medications. And we typically think that teriparatide as well as the newer drug romosozumab are quite meaningful because they are really effective, and they have proved to be significantly more effective than bisphosphonates. So when patients come along and do have a fracture, or if they have more than one fracture, we advise them to start with teriparatide right away, which is possible in Germany, or with romosozumab. Because these patients do have already a fracture, and we know that the use of teriparatide works in postoperatively quite well. It helps to prevent screw losing, as well as it can help even if you have an elective surgery or you plan an elective surgery, and then you prepare the patients beforehand. So it definitely makes sense to think about how to improve the bone quality, and teriparatide as well as romosozumab are options. So in conclusion, the OF classification, the score I showed you, and the current treatment recommendations do work. Obviously, we could prove this, but however, they're expert-based, and what they do, they're just reflecting the actual status and knowledge we have. It's not perfect, but I think it's a good help. You can use the OF score on a daily basis. You can judge the patient. You can see whether he or she gets better or not, and then decide whether to operate or not. The OF classification helps us to discuss about fracture types, and therefore we know I think it reflects more the typical fracture patterns, like in comparison to other classifications. The conservative therapy is definitely the first choice in the majority of patients, especially if they are mobile and the pain is moderate. However, remember that 1/3 of the patients fail, and do remember the risk factors. If we perform surgery, kyphoplasty and the hybrid stabilizations are our surgical workhorses. That's in the majority of patients we come along with this. Kyphoplasty is quite good, effective in pain treatment. However, if you have a deformity, so kyphosis, or if the vertebral body is really gone, then probably a hybrid stabilization is better, and you get more reliable results. More aggressive surgical strategies are sometimes necessary, especially for this old or failed conservative cases where you have where the vertebral body is more or less gone, where you have this Anderson lesions and where you have this severe deformities. Then you need more surgery, and here anterior posterior, if you can do it in a minimal invasive fashion, are quite effective too. However, comorbidities, adjacent fractures, and implant failures are still challenging, so we have not solved all the problems. The judgment of the frailty of the patient is helpful to estimate how likely complications are. So if a patient is really frail, we try to avoid the surgery, and so in order to reduce the chance that the patient do not profit from it at all. And of course, don't forget the adequate medication for the osteoporosis. That's crucial, to avoid further fractures and to reduce the mortality of the osteoporosis. Short outlook before I finish. about sacral fractures, osteoporotic sacral fractures. The same working group I was just talking to, so from the German Orthopedic and Trauma Society, has developed a pelvic classification for osteoporotic sacral and pelvic ring fractures. We have published this already, and the inter-rater reliability was substantial. It was really very good, and the intra-rater reliability was even perfect. So this is a relatively easy classification for sacral fractures. I would like to show it to you. It again is like the OF classification, has only 5 subgroups. It starts with the bone edema at any location of the pelvic ring, because sometimes if you perform an MRI and you see the coronal steer sequence, you accidentally see, oh, there's maybe one side, the sacrum is shining, the steer sequence, and then even if you don't see anything in a CT scan, but there's already a bone edema, and there's sometimes the cause of pain in patients if they come to you with low back pain. So I advise always to perform an MRI. If you perform an MRI of the lumbar spine, to perform an coronal steer sequence, because there you can detect whether they have sacral fracture. OFP2 is an isolated fracture of the anterior pelvic ring, uni or bilateral, typically something you would treat conservatively, of course. OFP3 is a unilateral sacral fracture with or without any lesion of the anterior ring. Here, then, depending on the type of there's dislocation or not, if the patient is in pain, you may start with therapy in terms of putting any kind of screws, mostly percutaneous. An OFP means a bilateral sacral fracture with or without any lesion of the anterior ring. Here, in many occasions, surgery with iliosacral or transiliosacral screws, or sometimes if you have a transverse component, even lumbopelvic stabilizations might be necessary. And the rather rare OFP5 are transiliacal or transiliosacral fractures with or without any lesion of the anterior ring. And together with this, some modifiers come. We have 3 modifiers here in this classification. They indicate more severe injury. A single or in combination are they possible. So one is a lateral process in the CT scan, like you can see under A here, where the arrow is. So because this is a sign that there's a higher degree of instability, then dislocation at any localization is another sign for instability, as well as vertebral body edema, like in that case, E and F. You can see in the CT scan in the ilium, you can't see anything, but then if you have an MRI, you see that's an additional edema. So these are 3 modifiers. And why do we need modifiers? Because we have developed a score for osteoporotic pelvic fractures. The score is currently only available in German. I apologize. We have not validated it and translated it to English yet, but you can see maybe that looks quite similar to the score I just presented to you with regard to the thoracolumbar fracture. This score here includes, again, the morphology, whether the patient is mobile or not, how the pain is, if they have neurological deficits, how the overall health status is, Asia, modified frailty index, etc., and some modifiers. And we just evaluated this score until last year, and we are now putting all the data together. We had, I think, roughly 500 patients included, and we will come up with our results soon, and then we hope that we can evaluate it internationally. So to conclude, here's some take-home literature for you. All of this is free access, whether they are the scores or the classification. We have developed an app which is website based of the OF score, ofscore.l7lc.org. So it's easy to use in daily practice. And there with the AO Spine together, we've even produced a classification video with may help you to use it and learn the classification if you're interested in. And with this, I would like to thank you for your attention. It was a pleasure for me to be here, and I'm looking forward for your questions. Thanks a lot.
Thanks a lot, Klaus, for the very nice presentation, comprehensive approach to the osteoporotic fragility fractures. And I asked to the participant to put their question in the chat. And there is one from the audience, which is actually, what do you mean by vertebral cleft on the X-rays and CT scan?
Yeah, so vertebral clefts are gaps in the vertebral body, which can be seen in the MRI because they include there's fluid, so water or any kind of body fluid in the vertebral body. So it's typically on T2, it's light. And in the CT scan, you see mostly a vacuum phenomena. So you see any kind of gap or void, you know. So this means, and if you compare it with the standing X-ray, you see that it's in the standing X-rays, it kyphoses. And then in the MRI, when they are so in a supine position, it opens up and then fluid gets into this. So there are gaps, voids in the vertebral bodies, and they're a sign of instability, and they're a risk factor for ongoing kyphosing and failure for conservative treatment.
Thanks for your answer. I see that Florian has a hand up. Please,
Yeah.
Florian.
Thank you, Klaus. Very, very nice presentation. I have a question regarding the conservative therapy and another question regarding the surgical therapy. For the conservative therapy, is there any role for bracing, or is bracing necessary? If bracing is necessary, in what subtype of fractures? I do not use it anymore. I just have the patients mobilized, try to have them pain-free without any bracing. What are your thoughts about this? And my second question would be about a surgical strategy. You showed some of the cases where you did go posterior and anterior, but in some cases it can be quite difficult to get a sufficient posterior correction in this osteoporotic soft bone when you go posterior first and try to correct the kyphosis and then go anterior. The alternative would be to do a vertical shortening or spinal shortening, where you do a PSO or wedge osteotomy to close a kyphotic deformity. There are worries that you're going to destabilize the spine even further if you take the posterior column. Well, what do you think about this shortening as to correct for those kyphotic deformities?
Yeah, Florian, great, important questions. Of course, difficult questions too. So bracing, when we in thoracolumbar trauma, in bone healthy patients, so not in the elderlies, there is no evidence at all that bracing works. So actually, there's no indication for bracing in young patients or patients with good bone stock. In the elderly patients, there are 2 studies showing that where the patients benefited. So even one was even as prospective and randomized. So a recent meta-analysis showed, however, that the evidence is still not there to conclude that bracing in the elderly is of any help. So in doubt, you can say bracing is not really something you have to do because the evidence is not good or not good enough to recommend it. So in general, we cannot really recommend bracing. What I see in the daily practice is that when we treat patients conservatively and they complain when they walk and stand about a lot of pain, then we ask the physiotherapy to help them a little bit and to stabilize them, sometimes manually, to give them some aid. And when the patient then say, well, yeah, that helps me, that is like somebody is holding me, somebody is giving me more better posture, then we prescribe an dynamic orthosis. So individually, I would say bracing makes sense. In general, we do not recommend bracing in these patients. The second question is about the how to reduce the fracture. So what I think is quite helpful is to perform, of course, to see what happens standing X-ray in comparison to CT scan or MRI. So you see how mobile it is. Even perform in older fractures hypomocleon, where you put a pillow or something under the back and then make an supine X-ray to see how it opens up. And then I decide if I see that there's mobility, and that they typically do not reduce physiologically, but if they markedly reduce, then I would say I would go for posterior because then I have a chance. But just doing some SPOs, some opening the facets, maybe even to correct them quite nicely. So, and the goal is to correct them to, I would say, age-adapted sagittal profile. That means that the idea is not to have an SVA of +5 centimeters, and it's ideally maybe on the S1 like in the 80-year-old patient I showed where the SVA was still 8, but I don't think that this is a big issue. So the idea is to put them back in a compensated sagittal balance, I would say, or disbalance, where the SVA is typically something between 5 and maximum like 8-9 centimeters. And if I see that they open up, I can do some SPOs or even sometimes Pontis and achieve this. But the more aggressive, the more I take away from the posterior elements, the longer the construct has to be. I think the more points you need to fix it, to assure fixation, and then the problem starts with adjacent segment problems. So the longer the constructs, the higher the risk of adjacent issue or problems is. Osteotomies, as like PSO, etc., I try to avoid. If it's a fixed deformity, I rather go from anterior, because typically, at least in my environment, we have the ability to do all this minimal invasive and thoracoscopically assisted, and then the blood loss is relatively low. And therefore, I can do this, or in the lumbar spine, even do a retroperitoneal or lumbotomy. This is, for me, easier. It's more effective and I have less blood loss than if I perform a PSO. So I personally try to avoid PSOs in the elderlies, because PSO take time. Typically, blood loss is relatively high, and then patients deteriorate and can develop complication. So Pontis, SPOs are good. Fixed deformity, I personally do an anterior release first, and then put the patient and then open up the patient. Does this answer your question?
Yes, I think so. And there are many questions coming up from the participants before giving the word to Hihab. I'd just like to ask you from Afghanistan, in case of fixation or screw loosening after fixation, what is your advice in terms of revision surgery? Is it difficult or not? And what do you suggest for?
Yeah, so it isn't a problem at all. If you, let's start differently. If you augment a screw, what you perform is the risk of pulling out the screw is definitely lower. So the force that withstand the screws is the pull-out forces, but not torque. So it's relatively easy to take out a screw which has been cemented, because these PMMA bridges break immediately. So you don't need a lot of force to take the screws out. If you want to put another screw in, I advise to tap, because then you have a chance that you can get in a bigger screw and cement it again. But taking out a cemented screw which got loose over there is not a problem, I would say.
And the second question is from Ukraine. Do you perform densitometry or calcium levels before each surgery?
In fractures, typically you don't have that time. If a patient has a kind of acute fractures, you have maybe 1 week. If possible, we do a CT scan mostly to judge the fracture, to classify it, etc. And then we perform a QCT, also quantitative CT scan, which is relatively easy. And everything above 130 is not a problem. Typically not everything from 100, below 100 is osteopenia, below 90, 80 is definitely severe osteoporosis. We advise to augment screws when the Hounsfield units are below 100. So everything below 100 should be, we advise to say, put in cement, also cement the screws. Typically, we advise the patients after our treatment to receive a DEXA measurement, because the medication and the medical therapy is based on DEXA measurement and not on QCT. So QCT is helpful for us surgeons to estimate whether the bone quality is good or not, and to judge whether we need any PMMA or not. But it's not good, or it's not a reliable or not evaluated parameter for medical therapy. If we have an elective patient, so we do a lot of deformities here, and we have older patients, and all the patients we do elective surgery when they need reduction or correction of deformity, and if they are older, the females are older than 50, we want a DEXA measurement or QCT beforehand. And if we see that they have an osteoporosis, we start with medical treatment before we perform the surgery, because it's elective surgery. We can do a deformity correction in 3 or 6 months. We don't have to do it right away. So they can get treatment beforehand. We don't check calcium levels. We don't check, because I think that doesn't make sense. typically we advise all the patients to take vitamin D because there's a lack of sun, at least here in our environment and in the winter. So there's vitamin D is, I would say, never a problem. So all of them get vitamin D before surgery and post-op surgery.
Thanks a lot. Hihab, you had a question to Klaus?
Yes, thank you very much, Klaus. Again, as always, great talks. My question is a little bit clinically based, simple. Do you have a cutoff time where you go from conservative to surgical treatment? Let's say if she doesn't have any progression of the deformity, only pain, how long would you wait for medical treatment?
Yeah, I think this depends a little bit on which society and you are and what the health system is and how much time you have. I mean, a patient who is mobile can be discharged and then can be, of course, can come back again in a week and receive a standing X-ray to see whether, you know, what happens and how the pain. In my experience is, if they do not really ongoing sintering means that they have ongoing kyphosing. So if they do not kyphose, then typically they are stable with the pain as well. So mostly in kyphosing comes together with pain, stable situation mostly with reduction of pain. So I think these standing X-rays are quite helpful to objectively judge what happens. If you have an inpatient and we do not get them really out of the bed, then we would say wait 3 to 5 days. We'd perform the score, and if they do not get better, we would then, after I would say 5 days, you would judge and say, okay, let's go for surgery. I mean, if we have an 05 or 04 with where it's clear, we go to surgery right away, like 2-3 days later. But the other patients receive typically a conservative trial of 5 to 7 days. And if they are not mobile enough, and the score says is above 6 points, we go for surgery. But you can, of course, if you have the ability, you can wait for longer. So, you know, it depends on the health system you're working in.
There is another question to you, Klaus, from the participants. In case of stabilization, when do you recommend to put screws into the vertebral fracture level? And when do you choose kyphoplasty or vertebroplasty instead?
Yeah, that's a good question. Well, we have some data with regard to this stabilization plus kyphoplasty. We do not have data available yet when you put this short screws in the vertebral body, like we do it in the patient with good bone stock. Why shouldn't it work? So I think it may work. How I judge it, if there's a chance that with the kyphoplasty I can put in cement, reduce the fracture, increase the height of the vertebral body, I would probably go for cement. If I see that there's a kind of fishbone vertebral body, if there's a lot of destruction, where I say, well, where will my cement go? So it's likely that I will have leakage. I would recommend, if I want to stay short, then I would go for an X screw. So if a kyphoplasty is possible, I do kyphoplasty. If I doubt, I put the short index screws. And this helps us to stay short, you know, to make a bisegmental stabilization and to put another short screw in the fractured vertebral body.
And do you find that cortical bone trajectory is beneficial for pedicle screws in osteoporotic patients?
Yeah, I can tell you a story. I mean, we have this robot, you know, and we have the Mazor robot, and therefore we said, oh, that's a great tool because these cortical bone trajectory screws, or Medtronic calls them midleft screws or something like this, they're not easy to place, and they have to be placed exactly, otherwise they do not work. So we said, oh, that's great. Now we have a robot, so we can do this. Yes, technically we could do this, but I can tell you, if you have maybe 1 or 2 segments, it may work. Everything below, we had failures, a lot of failures. So monosegmental or bisegmental stabilization may work. If you don't, you apply too much forces, so reduction is, I think, difficult. But just for stabilization, 1 segment or 2 segments work. But we used it for elective degenerative cases, and we had to revise almost all of them. You know, so That's my
Fine.
personal experience. Maybe we are not
It's
good
also
enough.
mine. It is also mine with these screws. And last question: what is ongoing sintering in your presentation?
Yeah,
Mean?
that's this ongoing, that's progressive kyphosing. So if the spine, if sintering means that the vertebral body height is decreasing over time, so that sinters goes together, and this comes typically with an ongoing kyphosing. So a situation where we see on the X-rays that the spine kyphoses more and more, that the vertebral body height is decreasing more and more.
Thanks a lot. Before giving the word to Florian for the closure, of course, a personal thank to you for joining us tonight. And I think that there are two main concepts which are very important, apart from the interest of your classification that we do use in Switzerland. It is also the assessment of post-traumatic deformity, because we know that especially in osteoporotic frail patients, deformity begets deformity. So there is an interest to restore the vertebral height and the parallelism on the end plates, in my opinion. And doing X-rays, standing X-rays is very important. We do still see a lot of bedridden patients in geriatric hospitals. They even don't send them to X-ray assessment because they're afraid about the instability. So the concept is these fractures are low energy fracture, so the pending instability is existing, but is not that high as a post-traumatic fracture in a young patient. And the second concept, of course, is the follow-up of this patient. If it's, although you choose for a conservative treatment, this patient must be seen again 1 week, 10 days afterwards with a new X-ray, because this is an ongoing process, and you might have OF2 fracture becoming OF3 or 4, and so with a pending instability. And the last but not least is also the importance of the interdisciplinary discussion, because, for example, in Switzerland, insurances will not reimburse the procedure if the case has not been discussed in this interdisciplinary way together with the rheumatologists or internal medicine doctors to share the decision about the indication to surgery or not. And of course, the main thing is that if you discuss with them before, they were ready to follow the patient and to start the medical treatment, which is crucial. This is part of the whole treatment. So again, a big thanks to you, Klaus, and Florian. I think it's time to close.
Yeah, thank you, Enrico. Yeah, it's time to close, and just you already concluded about the fragility fractures. Thank you, Klaus. Very nice presentation. I think it was a very fruitful discussion, and many points, many important points were touched and discussed after your excellent presentation. I'd like to thank, in addition to our presenter and moderators, I'd like to thank all attendees who joined us for this webinar in a series of spine section webinars. So our next webinar will not be on May 1, which will be our typical interval, the next scheduled time point, but in most countries this is a holiday. Therefore, we're going to have a webinar on May 8, which is going to be a joint webinar with the CSF section of the ENS. And it's the topic is spinal cord herniations, which will be given by Marcel Ivanov. So please come for this next joint section webinar of this CSF section and the spine section. But finally, all enjoy the evening. Have a good evening. Thanks again, Klaus. Have a good night. Thank you. Bye-bye.
Bye-bye. Thanks.